What exactly is HealthSpan and why does it matter more than ever? Well, I'm Dr. Mike Wall, and I recently had the privilege of attending the Global HealthSpan Summit in Riyadh, an event hosted by Hevolution, a foundation dedicated to advancing the science of healthy aging and ensuring that we not only live longer, but we live better. Today, I'm joined by Dr. James Kirkland, a leading researcher in the field of aging and a pioneer in the study of cellular senescence. A geriatrician and endocrinologist, Dr. Kirkland has spent his career exploring how we can target fundamental aging processes to improve health outcomes, extend health span, and prevent the cascade of diseases that often accompany aging. In our conversation, we'll dive into the cutting-edge science behind senescent cells, cells that stop functioning properly yet linger in the body, contributing to inflammation and disease. We'll explore the latest research on interventions from lifestyle changes to emerging therapeutics that may slow or even reverse aspects of aging. Dr. Kirkland also shares insights on how medical research is shifting from treating individual diseases to addressing the root causes of aging itself. So, let's get to our conversation with Dr. Kirkland. Hi, Dr. Kirkland. Welcome to the show.
Good to be here. Thanks.
Well, today we're at the Global HealthSpan Summit, and we're looking at all the science of what's happening inside of our body when we age. Maybe you could tell our listeners a little bit about yourself.
Yeah, I started off as a geriatrician. I'm from Canada originally. I did my training in Canada. Then I later did endocrinology as well as geriatrics. And then I decided, well, it's very important to develop better wheelchairs, walkers, and incontinence devices, not to detract from that at all. But I wanted to get into something more fundamental. And can we get at root cause contributors that result in the way of health expenditures, poor quality of life, and not only chronic but acute diseases as well by targeting fundamental aging processes which begin at or before conception and affect us throughout life.
Well, one of the areas that you're doing a lot of research in is called senescence. And that's a relatively new concept for a lot of people. Maybe we could start right at the beginning of it and you could explain what senescence is.
So cellular senescence is what we call a cell fate. Any kind of cell in your body can become senescent at any point during your life. And what senescent cells are is cells that have experienced an insult but don't quite die. In fact, when senescence gets switched on, these cells become resistant to dying, and they're only normally removed by the immune system. And they can produce a whole range of factors that can cause a lot of dysfunction. And they appear to integrate a lot of fundamental aging processes, and they appear to be precursors to cancers. We can't stop senescent cells from forming, and that's important because they're a defense against cancer, paradoxically. They're important in developing the fetus. They're important in wound healing. They're important even in childbirth. So we don't want to stop senescent cells from forming. But once they've formed, if they sit around too long, they're only normally removed by our immune system. If we don't get rid of them, they can cause immense damage, very small numbers. If we transplant senescent cells, for example, into mice, such that only 1 in 10,000 cells in that transplanted mouse is a senescent cell, that's sufficient in a middle-aged mouse to make it die earlier of every disease that mice naturally die from and to cause frailty and so forth. And the same kind of thing if we transplant organs from older donors into younger recipients. So one of the areas that some of the interventions that have been developed to target senescence in is being used for is actually so that we can use organs from older donors to put them into younger recipients.
Yeah, that's interesting. And these senescent cells, they get cleared less as we get older, or they accumulate more? How does aging have to do with the accumulation of these cells?
Well, again, these senescent cells, they develop in response to injury, but they also spread. Yeah. And they spread not only locally, they can spread at a great distance. So I mentioned the transplantation stuff. If you transplant senescent cells into the abdomen of mice, they start developing senescent cells from their own non-transplanted cells in their brains, their limbs, and elsewhere. So our view is there's a threshold. And once you're above that threshold, the rate of accumulation of senescent cells exceeds the ability of the immune system to clear them. And then they take off. And what we get is sort of like a hockey stick kind of pattern, right, where you get one age-related disease, the next one follows after that, and then the next one follows much faster after that, and then they appear in quick succession. So we see what we geriatricians call multimorbidity. And we get people who go from having one condition like diabetes to also having cancers, Alzheimer's disease, all kind of cardiovascular disease. And these things take off and people go from one medicine to being on 20 medicines. How can we stop that?
And I think that's the point. I think a lot of times people think about diseases as this causes this and this causes this. But what we find is that lifestyle, for example, or aging process is associated with a variety of diseases. They just manifest differently in different people. Is that part of the role of this?
Yes, there are tremendous differences between men and women across different populations. And we don't study these populations adequately in clinical trials. So often what we do in clinical trials is study a single disease with a single intervention, looking at a single outcome. We've got to change how we do clinical trials to thinking of the real world. And the real world that I see as a geriatrician is people coming in with 10 different problems. They're elderly, who tend to be people excluded from clinical trials, and they may be on 15 or 20 drugs. How do we generalize clinical trials to the real world?
That's a great question. And I think that the other thing is, when we start to develop these diseases, when we're on these medications, when we're doing these things that may be different than when we were young, does this amplify it? And like you said, it sort of turns to this hockey stick where there's actually more being produced that promotes the creation of these types of cells?
Yes, absolutely. And what we want to do is with some of these interventions, and some of these interventions are lifestyle interventions that are being tested at the moment. Things like diets, various forms of exercise, things like getting rid of sleep apnea, problem with too little oxygen getting in at night, right through to repurposed drugs or natural products, to new chemical entities, to completely new kinds of interventions that we've never thought about before. Can we get down the number of drugs that people are on? Can we get down the number of diseases, even once they're established? But importantly, can we prevent them? And how do we move backwards from doing safety trials in people who've already got serious disorders? Because we've always got to worry about things that sound too good to be true being too good to be true. We have to worry about side effects and downsides. So we have to start off with populations with serious disorders and then work to what we call secondary prevention. That's with people who've already got one disorder to prevent the next from occurring. And then maybe one day we'll get to primary prevention.
Preventative type medicine for that. I always tell people that high cholesterol isn't a Lipitor deficiency, but quite often in our world, it sort of seems like that. But, where I focus on wellness and our listeners are tuning in to hear about wellness, let's talk about some of those non-medical things that we can do that will improve these factors so that we don't have this risk of it. You mentioned fasting and exercise. How does that work and how effective are these modalities? To be honest, with most of these things, we don't know because they're not studied adequately. And what we need is the right kinds of clinical trials to see which kinds of lifestyle interventions really do work. There are some that there's no doubt about. Stopping smoking, there's no doubt about that one. There are others that look very promising, like dealing with problems with sleeping at night and not getting enough oxygen at night. There are things that we don't completely understand, like exercise. What kind of exercise? Who should do it? When? You're not going to prescribe heavy-duty resistance exercise to a 90-year-old woman who has 15 different problems and could break her arms. So these things aren't properly studied, and we need to think about these interventions as any other intervention, and we need to study these things carefully. So I'm really glad that Canada, like the United States, has emulated what we started off, that the National Institutes of Health in the US started off, the Translational Geroscience Network. That has only just recently been funded in Canada. We're collaborating with Canadians to do this. And there's also the Canadian Longitudinal Study on Aging, which is incredibly important in figuring out which kinds of preventive strategies are really going to work over which are bluster. What kinds of diets really work? Some are downright dangerous. Others might be truly beneficial, but we don't know. We have to do the research. That's incredible. Actually, my supervisor for my doctorate is part of the healthy aging study in Newfoundland and Labrador. And it's right. My research was in exercise and diet, but it's such a broad term, right? You just said some of these things can be dangerous. What's your advice to them as somebody who consults patients and does research in this field about if they're motivated to make a change, but they may be doing something that's not good for them? Like what's the best route for a general population?
Well, I think one of the things is common sense. Another thing that we need to do is we need to have more formal education of physicians about these issues and nurse practitioners and other groups. We need to include this in medical school curricula. And we need to remember that we've got what we call upside down U-shaped curves. So changes in food intake may benefit some people, but again, the last thing we would want to do is take a thin elderly person and put them on even more caloric restriction. The last thing we'd want to do with someone who's already doing a huge amount of exercise is give them even more, because the Navy in the United States, for example, is funding trials of using interventions that target fundamental aging processes to prevent consequences of too much exercise, because one of the main reasons the military in the US is having trouble manning ships or fielding Marine units is that the people have done too much exercise behind the lines and they're getting arthritis in the knees and microfractures.
Yeah, that's very interesting, right? I think that's that happy medium. We're able to do things we've never been able to do at a dose of exercise, or things that are specialized in a level. I remember in my research, I studied inflammatory markers, and we saw cytokines go up during high intensity training for general population. It wasn't good for them. The population that did enough did well, but they did too much. It was actually detrimental. And
this brings up another thing that we need is what we call biomarkers, and the right kinds of biomarkers. And biomarkers, I don't just mean things in blood or urine, although they're very, very promising things that are turning up. We need to think about designing the right kinds of wearable devices. We need to think about the right kinds of questionnaires that a physician could ask that would be brief and take not too much time, so that we can have personalized prescriptions of which things to do. And because each consumer has different needs. Why, for example, we discovered drugs called senolytics that specifically kill senescent cells. Why would you give a senolytic to someone who has very few senescent cells? So we need to be able to have ways where physicians and other healthcare practitioners, dentists, very much so, and others can prescribe the right series of interventions, right from lifestyle interventions through to drugs and through to other kinds of new interventions that are coming along for the right person at the right point and in the right sequence.
Well, you just mentioned the drugs that you guys are developing and you're researching. It's interesting. You mentioned organ transplant, where we have these senolytic cells throughout our body, and you said some of them are very beneficial for wound healing and things like this. Is that an opportunity to be able to use these on, say, a specific organ or a specific structure before you were to use it on a person, to be able to remove those cells prior to?
In fact, we've done a lot of work with close collaborators at the Brigham and Harvard. And that's just what we're doing. So we want to set up, in parallel to the Translational Geroscience Network, which does clinical trials of things like senolytics or rapamycin or NAD precursors or sirtuin agonists that some of your readers may have heard of, and lifestyle interventions. We also want to figure out, are there ways we can rehabilitate organs from older donors so we can use them in younger recipients? And those have moved to the point now where we're actually looking at organs that are discarded because they're from older donors, to see if, while they're on the systems that you transport those organs, say from a car crash site to the recipient, whether we can clear the senescent cells before that happens so that we can start using organs from older kidney donors. In the United States, for example, we're throwing away 24,000 kidneys a year, mainly because they're from older donors. If we could figure out how to use those organs, we'd solve the entire shortage of kidneys in the US for transplantation overnight, so that people don't have to wait 6 or 7 years and be on dialysis and have fistulas put in, which fail typically after 9 months. We're planning to do the same thing with heart transplants. There are already studies beginning with liver transplants. We haven't got to the point where we can do it in people, but this is being studied. Certainly in experimental animals, you can treat the donor, the organ itself, or the recipient with some of these agents, and you find the outcomes are dramatically improved.
That's absolutely incredible. I mean, you mentioned before about Canada taking a keen interest in this and looking at this type of research right now. What are the implications? Why is it so important demographically for a place like Canada? And what does it mean for our population that may benefit from these therapies when they finally come to market?
Well, one of the big issues is the lifespan, health span gap. So we've found throughout the world, or at least other collaborators of ours have found throughout the world, that median lifespan is increased. And that's mainly related to antibiotics, vaccination, and other kinds of things that have gone on. So we're finding there's a very large older population and a shrinking younger population. In most countries, the overall population is shrinking. But what's also happening is the gap between health span, which is a period during life when people can live free, independently, without pain, able to work if they want, cognitively intact, and the gap between health span and lifespan, where there's a period of disability towards the end of life, is increasing. And in Canada, it's increasing. In the United States, the gap between health span and lifespan for women is the highest in the world out of 183 WHO countries. It's 13.7 years.
So you can keep people alive for a long time, but their quality of life is down. I mean, from your gerontology side of things, how does it impact somebody's quality of life and those last years? And how does it improve if you're able to make that health span longer?
Well, it doesn't just affect the individual consumer. It affects their family, the healthcare system, healthcare costs. So this has huge ripple effects and makes me as a geriatrician, I've had very few patients ever come to me who are older and say, I want to live another 20 years. What they say to me is, I want to feel better. I want to be able to think more clearly. I want to be able, some people want to continue working. How do we do this? And how do we have good quality of life and then not have a period of horrible lingering with multiple disorders and diseases where we're not able to think clearly, where we're in pain, maybe in bed, incontinent? How can we shrink that period of life, which is very disabling for the person who has it, for their family, for the healthcare system, for costs, everything.
Yeah, we have the highest healthcare spend in the country in Newfoundland and the lowest life expectancy.
Yes.
Yes, it's a very challenging situation there. Being at the forefront of the research, where do you see the research in health span going, and how quickly do you think it's going to start impacting that health span for the general population?
It's very hard to predict. For example, with senolytics, the drugs that we discovered, or the interventions we discovered, and other things that have come along, I gave this stuff 5 years ago a 0.0001% chance of working when you get to clinical trials, because what you find in mice doesn't necessarily apply to people, or in rats. But when you go from preclinical studies, as we call them, in experimental animals or cell culture systems or organ cultures to people, only somewhere between 10 and 30% of clinical trials work, no matter how good the preclinical data look. So what we need to do is be prepared for failure of a lot of these interventions and not get completely switched off if some of these trials fail. So far, the trials are looking very promising. But given what I know and some of the things that aren't published yet that my colleagues and ourselves have been doing, I've moved from a 0.001% chance or less 5 years ago to maybe a 30 to 35% chance these things will work. But I'm not at 50% yet because I'm a skeptic. I'm a physician. First thing we get taught in medical school, the first hour, at least it used to be when I went through, was primum non nocere, the first line of the Hippocratic Oath, first do no harm. So we have to worry about that. And I'd say to the general public, be very careful about taking any of these interventions until we're convinced that they're going to be safe and helpful. As we were discussing earlier, there are some things that people can do, like watching their blood pressure, stopping smoking, healthy lifestyle in other ways that appear to work. But we've got to have people who are willing to enter clinical trials now that some of these networks are developing. We've got to ask people to not just buy things that they hear about in social media and try things out until we know from carefully controlled clinical trials that they work. We're trying to work at greatest speed possible. And I know the Canadian government is behind this because I'm on some of the advisory groups for the government and many of the provincial governments. We just have to get these trials done, and we have to see, is this a go or a no-go? Because if any of these things, if they happen to work, this could arguably, and I don't want to be too hyperbolic about it, but this could be as or more important than the discovery of antibiotics if these things really work.
That's unbelievable. And I can see why. I mean, you said it affects every system in the body. It's related to almost every type of aging condition that we have. And we all know that age is associated with almost everything that we develop.
Including in children.
including in children. Right, exactly. So there's before we move on to that, there's an expedited creation of these cells in children that have some sort of genetic or predisposition.
Or who've had chemotherapy for cancer, or all kinds of other things, that PTSD. There are all kinds of things that'll drive these processes.
So stress in one way or another.
Yeah.
So you're speaking at this conference, and you've come all the way to Saudi Arabia to meet with all these other researchers and present these findings. Why choose this as a venue to be able to present?
I wind up spending too much time on jets traveling around the world. I need to spend more time in our laboratory and with our patients, arguably. But I think this is something which virtually everybody across the world can see eye to eye on. Once politicians are educated about what the potential of this is, and not only the benefits to their constituents, but also the economic benefits that could accrue if these issues could be fixed. And if we don't do something about it, what the problems are. So I think there are governments that have a lot of insight into this and are willing to put resources behind this. Saudi is one of the leaders. Singapore is another one. We in North America need to push this up in our politicians' minds. And once it's explained to, a lot of the politicians in many countries are very, very smart people. They get it, and they're experiencing these kinds of things themselves or in their families. Mm-hmm. So this is something that could arguably draw humanity together. And if human life becomes more valuable, maybe we'd have arguably a gain. This may sound insane. We might have less wars.
Mm-hmm. I 1000% agree. And, we realize that biologically we're all so similar. We're all the same. There's a question that I've asked every expert in health from whatever walk of life they've come from around the world. And it's a simple question, so answer any way you want. But it's, what does the word health mean to you?
Health means to me living free, independent of pain, disability, being able to do what I want, and to not even think about my health because I'm happy and able to do what I want. And how do we preserve this in everybody?
Yeah, and that's a great question. Thank you so much for joining me today. I really appreciate it. It's a really enlightening conversation. I love when I get to meet people and learn something new, so thank you.
Thank you very much.
Well, that was Dr. James Kirkland, and that was today's conversation. But we're just getting started. We have many more interviews with leading experts from the Global HealthSpan Summit, where the brightest minds in the field are redefining what it means to age well. I'm Dr. Mike Wall, and that's today's episode, but we have lots more, so be sure to like and subscribe to learn from all the thought leaders that attended the Global HealthSpan Summit.